covered. I would like to introduce you to our two panelists, Joelle Puccio and Laura Churchill. Joelle Puccio is a registered nurse who has worked in perinatal and neonatal intensive care since 2004. They worked for 7 years as the Director of Women's Services for the People's Harm Reduction Alliance, a peer-run syringe service program in Seattle, Washington, and served on the board of directors for 4 years. They are a co-founder of the Academy of Perinatal Harm Reduction, whose mission is to improve the lives of pregnant and parenting people who use substances. They have been invited to speak at our conferences convened by the Centers for Disease Control and Prevention, the Academy of Neonatal Nurses, and the American College of Obstetricians and Gynecologists, and more. They currently travel the country in their RV with their 2 cats as a travel nurse in order to learn about the experience of families affected by perinatal substance use and pregnancy criminalization in varying geographic areas. They became passionate about advocating for people who use drugs after realizing that everything they had been taught about drugs from childhood through nursing school was wrong. Welcome, Joelle. Laura Churchill is the Director of Public Health at Greene County Public Health in Catskill, New York, where she has worked for 19 years. A board-certified nurse practitioner, she directed the Greene County Family Planning Program for the past 14 years. She received her BS in nursing at the University of Maryland in 1989, her master's/FNP at the State University of New York at Binghamton in 1995, and her Doctor of Nursing Practice in 2016 from State University of New York at Buffalo. Her master's thesis was employment and breastfeeding, and her doctoral capstone project was reducing chlamydia infections in Greene County. In 2019, she led the Family Planning Clinic in providing medication-assisted treatment for persons with opioid use disorder, a practice which continues today. She is passionate about decreasing barriers to healthcare access for all and using evidence-based strategies to improve health outcomes. Welcome, Laura. And with that, I will pass it to you, Joelle, to get us started.
Thank you so much, Joanna, for that lovely introduction. We only have a few minutes, so I'm going to dive right in. Thanks so much to everybody for coming. So as Joanna said, I'm one of the co-founders of the Academy of Perinatal Harm Reduction, and I wanted to do a quick plug for our Perinatal Substance Use Toolkit. This is a free digital resource. It's available in multiple languages, and it goes over all of the stuff I'm going to talk about in much more detail. If I do my job right, I hope I will leave you with thousands of questions. I am not being paid for today, and I have no relevant financial relationships. So we're going to talk a little bit about the basics of harm reduction, which I think this group knows probably pretty well. But what I find is that people who are really into harm reduction have trouble applying it suddenly when somebody becomes pregnant. So we'll kind of talk about it in that context. So there are lots of definitions of harm reduction, but at a very basic level, each of them includes at least 3 things. Respecting people who use drugs. So this means in general that we accept that adults who use drugs are capable of making decisions, they are worthy of respect, and we don't need to be treating them like children or as if they are incompetent because of what they put into their bodies. And this is true for pregnant people as well. Nobody sets out to be in chaotic drug use, and pregnant people are no different. We have to understand that pregnant people who use drugs are want to do their best. Improving the quality of life for people who use drugs. This one is typically a little bit easier for us medical types to wrap our heads around. However, when somebody becomes pregnant, we suddenly think that we are the ones who decide what improved quality of life is, rather than focusing on that patient-centered care and the patient's perception of improved quality of life. And then finally, promoting joy and pleasure. This is one that we miss for everybody, pregnant people included. We have these ideas about people with the capacity for pregnant that they should be selfless and they should be willing to give up anything for others, for their family, for their pregnancy. And we sometimes forget that women and other people who have the capacity for pregnancy are allowed to experience joy and pleasure, and that's okay. It's good even. So when we think about any positive change, of course, big ups to Dan Big and the Chicago Recovery Alliance for popularizing this phrase. We really mean any positive change. So in the context of pregnancy, this can be scary for folks. If you have somebody who is still slamming heroin every day, but they stopped drinking alcohol, that's any positive change, and that's good, and that needs to be celebrated. Um, we have to allow people to take small, manageable steps towards their goals rather than requiring perfection or nothing. So this is kind of demonstrating that incremental change. The next harm reduction catchphrase that we don't often apply to pregnancy is meeting people where they're at. So this means physically meeting people where they're at, having harm reduction services available in OB clinics, for example, in public health offices. It also means going to places where people live or congregate, like Dance Safe putting up harm reduction tents at festivals, or Chris Abert wandering around in parking garages, people going into tent encampments, women's shelters, these types of places. And then finally, meeting people where they're at also means meeting people where they're at on their values and their goals. We have to meet people physically, emotionally, and psychologically where they're at if we're going to even have a conversation, let alone provide effective treatment. So when we're thinking about harm reduction in the context of pregnancy and early parenting, we have to think about more than just drugs. And in reality, drugs represent a very small proportion of the harms faced by pregnant and parenting people with substance use disorder. We're looking at poverty, nutrition, access to healthcare, community support, environmental degradation, and so many more things. In the interest of time, we're just going to talk about criminalization and its ties to trauma for today. Now, when I talk about criminalization, I'm not just talking about handcuffs and courthouses and police. I'm also talking about the way that criminalization seeps into every aspect of life for someone who uses drugs. So even if they are not doing any criminal acts, there's a perception in society that people who use drugs are criminals and therefore ought to be punished, ought to have their rights curtailed. And this translates into what we know of as stigma. This also translates into a lot of folks in the helping professions, such as medicine and social work, shelter, and various other services, kind of being deputized by law enforcement to surveil their patients, clients, or people that come to them for help, to report them to government, law enforcement, or others, and therefore to become part of that system. This is the reason why punitive reactions to pregnancy and substance use result in people avoiding care, resulting in worse outcomes for babies and families. So when we're talking about harm reduction for pregnancy, we have to look at the whole picture. So what we end up with in our country and our society and much of the world due to our imperialist exporting of our drug policy is that we live in a society where pregnant people are blamed for negative outcomes. Pregnant people are expected to produce the kind of pregnancy outcome that we often as medical providers think they should, or else be punished. We know that this makes no sense because pregnancy is super dangerous in the United States, especially compared to other countries with industrialized medical systems. We have about 3% rate of birth defects, depending on how you quantify and where you measure miscarriage, about 5 to 25% in most places. And we have one of the highest maternal death rates of anywhere in the world with supposedly adequate medical care. There's no evidence to support these charges for most illicit substances, and that we get into that more in the toolkit. Most illicit substances are not associated with birth defects or preterm birth or other outcomes, other than, of course, neonatal opioid dependence and withdrawal. What this climate does is to create a new class of crime that can only be committed by people with the capacity for pregnancy. So this is, on its face, discriminatory based on gender and sex. I often wonder why I have to say this, but I do. Punitive measures do not make people healthier. Punishment is not healthcare. Surveillance is not healthcare. This is not helping. So why are we doing it? I'll talk very briefly about trauma-informed care. For this population in particular, people who use drugs, women and other people with the capacity for pregnancy, have very high rates of trauma. And when those identities intersect, we end up with a population that is very likely to have had an experience of trauma. Oftentimes, trauma caused by the helping professions, often medical care, social work, shelters, etc. We often hear reports of really abusive or medical treatment or maltreatment, such as refusing to give pain medicine to somebody undergoing a minor surgery or a procedure, et cetera, et cetera. So when we see these people, we have to recognize that already they have overcome massive hurdles, even asking for help. We have to make people feel welcome. It doesn't matter what medical intervention you do. It doesn't matter if you have the most perfect plan. If that person doesn't feel safe talking to you and seeking care in your location, they're not going to come back. And then we have failed. A lot of healthcare providers seem to have trouble with this concept because in our minds, we're just like, well, she shouldn't be using substances. She shouldn't be using substances while she's pregnant. But that's not really a modifiable factor that we can influence. It is not up to us as healthcare providers whether or not people who use substances. What is up to us is whether people who use substances have support or whether they're abandoned by our systems of care. So I'll just wrap up with kind of an overview of reproductive and perinatal harm reduction in general. This involves community support in the form of friends and families, community groups, doulas, and birth workers. This involves our ethically mandated responsibility by our boards of ethics to advocate for policy and legislative change that removes punitive interventions from this population. We have to include impacted people and pay them for their lived experience. We have to provide equitable and culturally competent and accessible care. We have to think about the social determinants of health. If somebody's not gaining enough weight during pregnancy, are they bad for not eating enough, or do they live in a food desert, or are they experiencing poverty? It's more than just sterile syringes and sterile supplies, although it absolutely is that. And then finally, I have to mention, especially due to recent things that are happening in this country, reproductive harm reduction includes gender affirming care for adults and children. That's vital. I have a ton of links to resources and other stuff that you might find interesting. Also, please email me anytime. I love to talk to people about this stuff. And with that, I will hand it off to Laura. Thank you so much.
Wow, that was so impressive. What an honor to be following you. And I really am grateful for this opportunity to be here today. I am going to talk about an experience that we have had here in Greene County. So my name is Laura Churchill, and I am the Director of Public Health, previously worked in the Family Planning Clinic until just recently. And my title is Supportive Medication Opioid Use Disorder Treatment for Pregnant and Parenting Women. And so I'm going to shift a little bit from Joelle's presentation to talk not only about women who are pregnant, but women who are parenting. So why did we start doing this? Well, you can see in red, Greene County.
Laura, sorry to interrupt for 1 second. If you need to take a few extra minutes, you can do that.
Okay.
Thanks.
Oh, if I need to take a few extra minutes with my presentation.
Yes, please.
Okay, great. All right, so over here in the red, you can see this is Greene County in upstate New York. We're about 2 hours north of New York City and about 4 hours south of Montreal. And you can see from this case rate here mix in about 2017-18, we had a very high opioid overdose rate of 27.4. And that was above the New York State average of 19. And it was about this time in 2018 that the federal government changed the regulations to allow nurse practitioners to prescribe buprenorphine. So at the same time, the New York State Health Department decided that they wanted to really promote the access to buprenorphine in the state. So we were lucky enough to receive training through the New York State Health Department, through physicians, I believe, who are on this call today. And so we decided that this was something that we needed to do. Unfortunately, the rates have continued to go up. And in 2021, the case rate for Greene County was 46.3 per 100,000. And that was almost double the New York State rate. I also draw your attention to the neonatal abstinence syndrome rate for Greene County is 15.4 per 1,000, and that's nearly double the state rate of 8.8. So what is family planning? So I take this little graphic here from the CDC under the Quality Family Planning guidelines, and in the center in gold are the standard services that we provide in family planning and have always provided. So contraception, pregnancy testing, helping women achieve a pregnancy. Women who are experiencing infertility can access services. We call it level 1 infertility testing, and then we refer them if we can't find anything initially wrong. Preconception health, I want to discuss today. Obviously, we do STD treatment. In the blue bucket, you'll see related health services. So this is where we do screening for breast and cervical cancer and other cancers. And then in the outer ring here in purple is other preventive health services. So this is where we see the treatment for opioid use disorder kind of falling. And I know it describes screening for lipid disorders. We also do depression screening and other things. But this is where we see this additional wraparound service. And I will tell you that it wasn't anyone's mandate for us to do this. Our patients were getting out of rehabs. They were not able to access services. They were overdosing. And they were really at the same time asking for the services at the same time we were being trained on it. So what I want you to think about is when a woman presents to your care, wherever it is, wherever you are on a continuum of healthcare, if someone is of reproductive age, and I'm now describing people who identify as cisgender females, they could become pregnant unless they're preventing pregnancy. So one of the things that a family planning clinic offers is low threshold access to same day, highly effective contraceptives. So we talk about low threshold access to buprenorphine. We've already been providing this access for same day, long acting reversible contraceptives. So that would include an IUD or an Nexplanon. So somebody comes in that day, they need it, they want it, they get it. There used to be barriers to care for that, and we have eliminated them because research showed they were unnecessary. We also have a pharmacy where we dispense pills, rings, and depot. Again, we do level 1 infertility. And why are we poised? Why is this not a bad place for us to provide MOUD? Well, it has to do with the skilled providers that we have. We are used to treating people who have sexually transmitted infections, HIV, unintended pregnancies, and we don't sit here in judgment and say, wow, you've got chlamydia again. We're not going to treat you. You're a bad person. So we really have been already providing very low threshold care to people who are at a critical point in their life. So when we started adding this low threshold MOUD in 2019, patients that we had seen for years that had not told us they were using drugs suddenly said, hey, my gosh, you're treating this now. I have a problem. Can you help me? And so it was very affirming for us to realize it. And we're very good at maintaining confidentiality. So the best time for us to intervene in a woman who uses drugs is in a preconception setting. So what does that mean? Before they become pregnant. So if they tell us that they're using drugs and they don't want to use drugs anymore, they don't want to use opioids, this is a time for us to intervene. And we have already been providing, as I mentioned, HIV, Hep C, and STI testing and treatment. In addition to that, our clinic offers condoms, fentanyl, and xylazine test strips. I shout out to the Matters program for their xylazine test strips, and of course, Narcan. But what else can we do to help women who want to become pregnant? Well, we can offer a script for prenatal vitamins. We can help them stop smoking, and we can help them if they are interested in getting on MOUD, which we started in 2019. Our clinic does not mandate that somebody have any other services but the prescription. However, that being said, over the years, we have begun to build some supports for people, including referrals to social work inside our clinic, co-locating someone 1 day a week. There's an intensive case manager through DSS that we can use, and peer recovery coaches. And then a woman who becomes pregnant is either in our program during their pregnancy, and those people are safely maintained on their buprenorphine, or they enter the program being pregnant. This is a critical time, and I am not an expert in OB care here, but I will tell you that somebody that comes in that's injecting heroin or fentanyl, right now it's mostly fentanyl, they are very difficult to get onto MOUD in the setting that we have. So we are unable to really put them on buprenorphine because of the risk of preterm birth. So that is not a time that you want somebody to go into withdrawal. And so I had a patient who came in her third trimester in the fall of this year, fall of last year, and unfortunately, she was not a candidate for us to initiate buprenorphine. So one of the challenges is that we have no other providers for methadone in our community, but I was able to connect her to a peer who then 2 weeks later got her into a methadone program, and she did deliver while she was on methadone. But it is a problem, and it is why it's really important to kind of look at where a woman is in their life and figure out, what is it that you need? Do you want to become pregnant? How can we help you? How can we help you actually have a safe pregnancy outcome? When you are pregnant, how can we support you? And I think we heard that quite nicely in Joelle's presentation. And then finally, what about postpartum? So a person who has delivered a baby, who has been using drugs, or who is on buprenorphine probably wants to delay pregnancy. And what we know, the research tells us that people who use drugs have very high rates of unintended pregnancy. The literature shows that it's about 85, 84%. That is compared to the general population of about 45%. And the unintended pregnancy rate in this country is actually falling for all women. It used to be 50% or more, and now it's down to 45. And I'd like to think that's because of the access women have to the long-acting reversible contraceptives. However, women who use drugs face this stigma of accessing care, whether it's in a family planning clinic, an OB clinic, or anywhere. So this stigma that we talked about really can prevent them from going into even access contraceptive care. We talked about, and Joelle did a good job of talking about, the fear of criminalization and loss of child custody. And that's certainly been an overarching theme that we've heard from our patients that we serve, is this concern about whether they can parent their children, that they are known by CPS. You know, there's a lot of stigma in the community. When we did a look back on the charts and the cases that we've seen, we were able to identify patients who were at risk for pregnancy who were treated in our MOUD program. So we excluded anyone that reported being male, was abstinent, who had a same-sex partner, and 94 patients were identified who would be at risk for unplanned pregnancy. When we looked at them, their charts, we could see that the majority of 24% had chosen tubal ligation for their method. 21% though were using a long-acting reversible contraceptive, either an IUD or Nexplanon, and 15% were using hormonal contraceptives. So nearly half, or 45% of women who were in our program accessing buprenorphine had chosen to have a very highly effective method to prevent them from having an unintended pregnancy. I had a patient, so the etonogestrel rod or Nexplanon is good for about 3 to 4 years. And sometimes we put these things in and we do not see the patients come back until it's time to change them out. So I have a case of this one woman who came in to have hers removed and replaced, and she reported that we had put it in while she was in active drug use. She hadn't disclosed it to us at the time, but after that, she went into treatment and she was in recovery, and she was so grateful that she had this birth control method during that time. So that was one less thing that she had to deal with while she was dealing with her recovery. So it's really helpful to meet people where they're at and provide them with what they want. It's not about us. What are the challenges? Well, some of the big challenges I think I talked about, but essentially buprenorphine induction in pregnancy due to fentanyl is nearly impossible. Because we don't have a methadone provider in the county, everyone needs to leave the county to access methadone care. Unfortunately, we only have one OBGYN provider in all of the county, and she's a wonderful midwife who provides very good care, but she doesn't do specialty care. So whenever somebody comes in who's being treated either with buprenorphine or methadone, or who is in active substance use, they get referred out of county to a specialty care. And that is a barrier right there. So is the barrier of not having a hospital for them to deliver at. And I'm researching this right now because a county near us is also closing their OB unit. And it does create big, huge barriers. And this is a population that does not need any more barriers when they're accessing care. So we have to be thinking about that as we make decisions about healthcare access. I know we've all talked about Child Protective Services, and while I respect their need to do their work, the point of this sometimes is very concerning to me, because so many of the people that we see are successful in our program, and though they're on buprenorphine in pregnancy, they become, they're very good parents. I will say that we have seen over time people, and I think it goes back to what Joanne said, is just give it time. Sometimes these models need to take time to show the rest of the population what we can do. But many of the women who have come into our program are not parenting their first or second child, but they're able to either restore custody of their children, or subsequent pregnancies, they're able to maintain custody. And so I'm going to end here with a success story. And this is a patient case study. And just so you know, I did receive permission from her to discuss her case. She was very delighted that we could do this. But this is a patient who had been in our program in family planning for years. When she came in to access care for our MOUD, she was 25. She was homeless. She described she was couch surfing, being ejected from DSS housing for a positive drug screen. I'm not sure what it's like in the communities that you serve, but in New York State, there are regulations, and one cannot get emergency housing if they have a positive drug screen, which of course makes it hard for people using drugs to have housing when they don't have it. What's really important here is to see her history. This woman had been to 6 previous detox centers and had an elective, so ETOP means elective termination of pregnancy 1 month earlier. So this is somebody who was really struggling in her life. She was injecting heroin at the time. It was heroin. And probably fentanyl, but more so heroin, because this is several years ago. She had willingly given over custody of her first 2 children to her family member, and she was Hep C positive. She initiated Suboxone with support from the SERPA that we had on staff at the time. And she did really well. She did so well, in fact, that she had a subsequent healthy pregnancy in our program. She delivered a healthy infant while she was maintained on Subutex. There was a CPS referral, but there was no interruption in custody for her for this child. And there are some studies that do show that when somebody is taking medication-assisted treatment or MOUD, they do have increased odds of having custody maintained. She later went on to become a SERPA herself. She transitioned to the injectable form of known as Sublocade, which, thank you, Dr. Batson, for that great presentation. And since then, she has weaned off of all opioids, including the Sublocade. And when she and I talked about us using this case, she wanted you to know that the most important thing that she found after being grateful for having this program to access care in was that after she delivered, she really doubted her confidence in her ability to parent. She said, I couldn't even believe I could take care of myself, much less take care of my baby. So we had referred her for MSW counseling, and she did maintain counseling. Her baby was born healthy and I'm happy to say Hep C negative. And then once she delivered, she was treated for Hep C and is now Hep C negative. So she is doing well. She is a success. She is one of many. And I call this out to you because I know that if we can do this here in our tiny family planning clinic, wherever you are, you can do it too. And thank you to our previous presenters for all of their great work. I think we're going to open it up now to questions and answers.
Well, thank you, Laura and Joelle. In the interest of being mindful of time, I think we're going to answer questions offline in the chat. And Paul, I'm going to pass it back to you.